Hello, I'm Dr. Eric Alskog from the Department of Neurology at the Mayo Clinic in Rochester, the section of movement disorders, and I was invited to tell you about a few of the high points from the paper that is coming out in the December issue of the Mayo Clinic Proceedings entitled Cheaper, Simpler, and Better, Tips for Treating Seniors with Parkinson's Disease. So this is a subject near and dear to my heart. I see a lot of folks with Parkinson's disease. I've been seeing them and trying to help them over the past 30 years, and there are a few basic principles that I thought are absolutely crucial in treating them. And moreover, I thought that the treatment really should not be confined to neurologists, but treatment of seniors with Parkinson's disease is something that really ought to be in the domain of primary care physicians and internists, and that's where I would like to see it go more and more. So this is bread and butter medicine. Parkinson's disease is common. This is not a rare disorder. By one estimate, there are about 1 million people with Parkinson's disease in the United States. Very common, very treatable. Now, we do not have any medications that get at the cause of Parkinson's disease. Some have been advocated, but really what we're doing is treating the symptoms. And if you go back to the basic clinical trials on Parkinson's disease treatment, we are treating the symptoms. So what's the best medicine for treating the symptoms? Well, it's a medicine that's about 40 years old. It's Carbidopa, Levodopa. And there have been a number of competitors that are appropriate in certain situations. But if you're talking about seniors, if you know Carbidopa, Levodopa, and are good at using that, you can change a lot of lives for the better among people with Parkinson's disease. The people with Parkinson's disease have a dopamine deficiency, and this is what we are trying to replenish with levodopa therapy. So obviously levodopa is the precursor to dopamine. This is by far the most efficacious way that we can replenish brain dopamine. Now, in the past 20 years or so, there have been quite a few papers written about how we should defer levodopa, we should keep the doses low, and this conservative treatment, I think, is doing a lot more harm than good. If you don't use it, you'll lose it. And I think that's what we've done to a generation of people with Parkinson's disease. We have been collectively very conservative in using levodopa therapy, and so we've relegated the generation of Parkinson's disease patients to the couch, watching TV, not going out, not exercising, and there is now an emerging literature suggesting that exercise does a lot of good things to the brain, and we should not be depriving folks with Parkinson's disease with the best treatment and trying to withhold it for some future date for reasons that really have not been proven. So let's start from that premise. We have the best medicine out there, Carbidopa, Levodopa. How should we use it? Well, it turns out the simplest way to use it is with the old-fashioned 25-100 Carbidopa Levodopa tablets, the regular formulation, not the controlled release, the regular formulation using the 25-100 formulation. That's 25 milligrams of Carbidopa, 100 milligrams of Levodopa. And I'll tell you my strategy for initiating that. It's a single 25-100 tablet an hour before each of 3 meals. Why an hour? Because Levodopa is a large neutral amino acid. When you consume proteins, which is our meals, the proteins are digested into the constituent large neutral amino acids, and they compete with levodopa at the blood-brain barrier, where there is an active transport mechanism that is easily saturated with dietary amino acids. So you need to take Carbidopa, Levodopa on an empty stomach, and really to be certain that you're doing it properly, tell your patients to take it at least an hour before meals. So you start out with 1 tablet 3 times a day. Typically that's too low to do a lot of good, so I have a schedule. 1 tablet 3 times a day. The next week, 1 week later, 1.5 tablets 3 times a day, then 2 tablets 3 times a day, then 2.5 tablets 3 times a day. And clearly the point of diminishing returns for people with Parkinson's disease is 2.5 and at the most 3 tablets at a time, or 3 tablets 3 times a day. So I have never seen people in my practice who say I did better on 4 tablets or 5 tablets or 6 tablets, provided it's the immediate release formulation taken on an empty stomach. So that's an important thing to know. Now you can always go backwards. If they come back to see you in 6 weeks and they say, you know, I was doing just as well on 2 tablets 3 times a day as 2.5 or 3, can always go backwards. And then that's their maintenance dose, and then that's what you maintain. What's the target you're trying to achieve? Keeping people ambulatory and active and fully engaged in their lives. Now, there are a couple sidelights here that are worthwhile mentioning. So the issue always comes up, well, what about dyskinesias? What about wearing off effects? Well, those are not things that start early in the course of Parkinson's disease. These start to surface after some years. And so this reflects an unstable levodopa response. So this is a little bit like a type 1 diabetic getting insulin. So insulin typically early on in diabetics has a very stable response. You can get the blood sugar targeted to where you need it, and pretty easy to treat type 1 diabetes. After a number of years, there is a percentage of people that become brittle diabetics where you can't stabilize the blood sugar. And so this parallels what happens in Parkinson's disease. And in Parkinson's disease, if you live long enough and have it long enough, typically the responses start to take on this short duration type of pattern. So early on, the responses are long-standing. So it's an effect that builds up over about a week's time on a given dose. After several years, more of the response gets tied to the dose you just took. And these are the short duration responses responsible for fluctuations. These are the same responses also that are linked to involuntary movements, choreiform movements, dyskinesias. And so dyskinesias reflect too good of an effect. So what do you do about short duration responses? You use the dose that works the best, and you shorten the interval between doses to match the response duration. You don't worry about number of doses or tablets per day, and whatever that person needs, you give them. Sometimes they need this at night to cover sleep. Insomnia is common among people with Parkinson's disease, and if it's not insomnia they've had all their lives, then they simply need a full dose of Carbidopa, Levodopa, perhaps at bedtime and perhaps again during the night. So what do you do about people that come back to see the clinician and now they've got a lot of wiggly movements? Well, those are the dyskinesias. Those are the choreiform movements. And choreiform movements reflect an overdose effect. Now, that's not dangerous, but obviously you want to get rid of those if you can. And they relate to the dose the person just took. So dyskinesias occurring now have nothing to do with the dose you took yesterday or even 8 hours before. So what do you do about that? Well, you lower each dose. So if people come back to see the clinician and they say, I have a lot of dyskinesias, and you see those and they're on 2.5 tablets each dose, then you reduce the dose from 2.5 down to 2. If that isn't enough, then you can go down from 2 to 1.5 and so on. And now what's happened sometimes is as you lower the dose, then the Parkinsonism is not as well controlled. And that may happen. Then you have a decision to make. Is this, which is more troublesome, the dyskinesias or the Parkinsonism? And that sometimes, that can be a problem, but the patient can be a party to the decision. So there you have it. Carbidopa, Levodopa. Do you need all kinds of other drugs? Do you need Mirapex and Requip and Comtan and Azilect and Soligeline, Depronil? Well, you know, I say let's keep things simple. Stick with the old best drug, Carbidopa, Levodopa, and you will have a very gratifying Parkinson's disease practice. The best of luck in treating your Parkinson's disease community. Thank you.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.